Hi, and welcome to this revision video on chronic myeloid leukemia. My name is Harini, and I'm a haematology registrar in the UK. This video is based for revision purposes for the FRC path, and it's based on the BSH guidelines, so hopefully you find it useful. The fusion oncoprotein BCR-ABL defines CML. It happens because of the reciprocal translocation between chromosomes 9 and 22. The ABL1 gene encodes a tyrosine kinase on chromosome 9, and the BCR is the breakpoint cluster region on chromosome 22. The translated oncoprotein expresses a defective tyrosine kinase, and its downstream pathways include JAK-STATs and PI3K, and they're involved in cell growth, cell survival, and inhibition of apoptosis. 98% of the cases of the Philadelphia chromosome express an mRNA in which the BCR comes from exon 13 or exon 14, and it joins the ABL on exon 2. The remaining 2 to 3% express atypical mRNA fusions involving exons broken at E1, E6, E8, or E19 of the BCR or ABL3. It's important to determine the transcript type prior to starting treatment to make sure that you're effectively monitoring the correct molecular response. And also, if the patient develops resistance to a tyrosine kinase inhibitor, then you look for mutational analysis on the kinase domain of the tyrosine kinase. So the clinical hallmark of CML is the uncontrolled production of mature and maturing granulocytes, predominantly neutrophils, but also basophils and eosinophils. In the absence of treatment, CML can have a triphasic or biphasic clinical course as it progresses from chronic phase and an old money accelerated phase onto a terminal blast crisis. The WHO version 5 recently in 22 has taken out accelerated phase as a diagnostic criteria, and we'll come on to why the emphasis has been taken away in the later slide. And sometimes it can go from chronic phase directly to blast crisis, especially when the blast phase is lymphoid in character. Generally speaking, it can accelerate from chronic to blast crisis when your neutrophil differentiation becomes progressively impaired and the leukocyte counts are more difficult to control with treatment. The blast crisis phase resembles acute leukemia with a blast percentage of more than 20% in the bone marrow. CML normally occurs in 40 to 60-year-olds, but it can occur in children and neonates. There's a slight male predominance, and ionizing radiation is the only known risk factor. In about 50% of cases, the diagnosis is made incidentally on a routine blood count. So the clinical features may include weight loss or night sweats because you've got a high turnover of your bone marrow and hypermetabolism. You can get abdominal pain and fullness from splenomegaly. That's because of high numbers of circulating blood cells, as well as extramedullary hemopoiesis because you've got less room in your bone marrow due to the large number of granulocytes. You can get bruising and bleeding from low platelet function again because there's less room on the bone marrow floor. So in CML morphology, the chronic phase is usually hypercellular as a result of markedly increased myeloid activity. The myeloid maturation is normal, so there's not really any dysplastic features, it's slightly left shifted, and the blasts are usually less than 5%. The myeloid to erythroid ratio is markedly increased, and the megakaryocyte numbers can be either increased or decreased. You can see increased reticulum fibers in about 30% of cases, and that correlates with a larger spleen. You can also sometimes see pseudogaucher cells, and that's seen as sort of blue histiocytes with onion skin features, and that can be because of increased phagocytic cells, and that also contributes to splenomegaly. They're very similar in appearance to Gaucher's disease. When you have an accumulation of cytogenetic abnormalities more than what you saw at baseline, so these abnormalities might include a duplication of the Philadelphia chromosome or trisomy 8 or 19 or isochrome 17q that causes CML to progress from chronic phase to advanced phase towards blast phase, and that can occur within 1 to 2 years without appropriate treatment. The CML blast phase is characterized by rapidly rising blast counts and marrow failure, so you will get cytopenias as a result of the uninhibited growth of the myeloid precursors with absence of maturation or differentiation. Morphologically, it's quite indistinguishable from other cases of acute leukemia, and in about 70% of the cases, the blasts are of myeloid lineage by morphology and immunophenotype. As mentioned before in the new WHO criteria, there's been a removal of accelerated phase and more emphasis on resistance of treatment stemming from a mutation in the ABL or the accumulation of additional cytogenetic abnormalities, which caused the CML to progress from chronic phase to blast phase. And the criteria for blast phase includes myeloid blast count of more than 20% in the bone marrow, or the presence of more than 20% blasts in the peripheral blood, or increase of lymphoblasts in the peripheral blood and bone marrow, but the percentage here is less clear. The differentials you might consider here may be BCR-ABL negative CML, and in those cases you need to be ruling out other causes of myeloproliferative neoplasms like polycythemia vera and essential thrombocythemia. Based on your bone marrow findings, you could think about chronic neutrophilic leukemia, which is very rare, again with a blast count less than 5%, and you might look for specific mutations such as CSF3R, or chronic eosinophilic leukemia, which again has specific mutations like PDGFRA, which may be detected on cytogenetics, or chronic monocytic leukemia or myelomonocytic leukemia, which is based on morphology and again cytogenetics. At diagnosis, the bone marrow aspirate should be performed to fulfill karyotype analysis to confirm the phase of the disease, and it's also important to establish the fusion type of the BCR-ABL protein and specifically work out the molecular transcript type of the protein so it can be used to monitor response to treatment. The bone marrow is also used to calculate the ETLS or SoCal score to inform the risk group and treatment choice for the patient. So the SoCal score is shown here below, and it includes the platelet count, the spleen size, and blast percentage, as well as age of the patient. So in the treatment of chronic phase, for many patients, imatinib is used first line, as it has a remarkably similar effectiveness when pitted against a second-generation tyrosine kinase inhibitor. The majority of patients in the German CML4 study, 88%, showed major molecular response by 10 years, and in children first-line imatinib achieved 60 to 70% complete cytogenetic response. And some groups may benefit from a second-generation TKI upfront. It might be those with a higher or intermediate ETLS or SoCal score, or women who wish to have children and want to achieve a rapid molecular response. It can also be used in younger patients, normally under the age of 30, who are excellent candidates for stem cell transplant. So comorbidities should always be used to help choose the right second-generation tyrosine kinase inhibitor. Dasatinib has an intermediate risk of exacerbating heart failure, GI bleeding, and should be avoided in COPD and pulmonary hypertension. Nilotinib should be avoided in hypertension, ischemic heart disease, central venous thrombosis, and peripheral arterial occlusive disease. And it can cause prolonged QT, and it should be avoided in diabetes. Imatinib is better tolerated, but should be cautioned in abnormal liver function and congestive cardiac failure. Bosutinib is not approved for NICE in first-line therapy, but it can be used in second-line and can be used in most comorbidities except GI bleeding or abnormal liver function. About 5 to 10 patients will present de novo in blast crisis or be gaining multiple cytogenetic abnormalities indicating an accelerated phase. So allogeneic stem cell transplant is recommended for the majority of these eligible patients. And the BSH guidelines advocate using a second generation TKI to achieve the chronic phase response according to appropriate timeline milestones, and to proceed to an allograft if suboptimal responses are achieved with a second generation TKI. For patients in blast crisis, it's the most common approach in the UK to treat with FLAG-IDA first, and then proceed to an allograft if eligible. There is some evidence that dasatinib crosses the blood-brain barrier, so if you've got a lymphoid blast crisis, it's preferred to give dasatinib along with intrathecal chemotherapy. Assessing treatment response is best done by molecular monitoring to identify response and developing resistance to a current TKI. It's performed by rapid sequencing PCR from the total peripheral blood leukocytes. So analysis from the CML4 study showed that patients who still had a BCR-ABL transcript above 1% at 6 months were associated with significantly lower 5-year survival, but still around 89%. With longer-term tyrosine kinase treatment of less than 0.1% at 12 months is associated with a durable complete cytogenetic remission, and that's when you say you've achieved major molecular response. So patients on TKI therapy should be monitored every 3 months until they achieve a stable major molecular response for at least a year, and then thereafter followed at a 3 to 6 monthly interval to measure whether they have a deep response. But what do you do if the tyrosine kinase is not working and the patient's losing response? Well, you could change to an alternative tyrosine kinase inhibitor if there's failure of first-line therapy. And the choice of second-line therapy is based on comorbidities, and you initially have to be guided by BCR-ABL kinase domain mutational analysis. So you would repeat a bone marrow and check that the patient is still in the chronic phase and not going towards blast crisis. It's no longer recommended for patients to escalate their dose of imatinib if they are failing the standard dose, though 600 milligrams could be considered for people with a suboptimal response with no evidence of a mutation and they're tolerating the standard dose. Although failure to achieve BCR-ABL as a percentage of less than 10% at 3 months identifies a group of patients with poorer survival, there's no evidence that changing the therapy at the 3-month point improves overall survival. So you may want to hang on to the next monitoring junction at 6 months before deciding to change treatment. You'd want to take into account the actual level of the BCR-ABL percentage of bad versus good, and the initial risk score and any pre-existing comorbidities before making a decision to continue or switch to second-line treatment. Outcomes from an allogenic stem cell transplant in chronic phase of CML patients have continued to improve since the 1990s, with overall survival rates of over 85% for people in chronic phase. The current recommendations advise that allogenic transplant should be reserved for patients who are resistant to or intolerant of at least one second-generation TKI, and possibly to a third-generation TKI like ponatinib. The dose intensity of a transplant conditioning remains debatable, although a lower CML burden at the time of the transplant is associated with a better outcome. However, there's no need to deepen the cytogenetic response or molecular response prior to a transplant, like for an acute leukemia. Patients who might experience a post-transplant molecular relapse can regain molecular remission with a donor lymphocyte infusion or more TKI therapy that they haven't been exposed to before. A trial of a third-generation TKI is reasonable prior to committing to a transplantation. Some patients with intolerance to multiple tyrosine kinase inhibitors may justifiably proceed to fourth-line therapy. There are many side effects of tyrosine kinase inhibitors, such as skin problems with alopecia, sweating, and itching. You can use antihistamines for this, or try reducing the dose of the TKI, or using topical steroids. They may experience myalgia. Again, reduction of the tyrosine kinase inhibitor may help with this. Certain raised LFTs, such as bilirubin, is noted with nilotinib, and you can use steroids for elevated transaminitis. It's common to get shortness of breath for a number of reasons, because of pleural or pericardial effusions or pulmonary arterial hypertension. So it's important to investigate it thoroughly with an ECG looking for arrhythmias, prolonged QT, chest X-ray looking for the effusion, and echo for pulmonary hypertension, or a CTPA for a PE. Patients can get migraines and headaches, and therefore you might want to consider a switch of the TKI. It's important to be vigilant in patients who've had previous cardiovascular events, such as an arterial thrombus and an MI or a stroke, and you would offer them secondary prevention if their 10-year cardiovascular risk is more than 10%. You'd offer them atorvastatin 20 milligrams, and specifically if they had carotid artery stenosis of more than 50%, you would offer them aspirin. It's important to measure the blood pressure before and during TKI treatment in clinic, and you would suspend the TKI if the blood pressure is above 180 over 110. ECG is really important, especially for bosutinib and nilotinib, as they can cause QT prolongation. And if that starts happening, you need to measure the electrolytes and refer them on. Arterial thrombosis are rare, but they can be seen in nilotinib and ponatinib. It's important to be vigilant about cardiovascular side effects. It's really common to get hypertension in bosutinib, dasatinib, and nilotinib, and it's very common in ponatinib. Pleural effusions are very common in dasatinib, and you would have to suspend the TKI and restart at a lower dose on resolution, around 50%. Normally, you don't need to drain the pleural effusion. Pericardial effusion has been seen in ponatinib, bosutinib, and dasatinib. Pulmonary hypertension is very common in dasatinib, as well as pulmonary edema, and QT prolongation can be seen in bosutinib and nilotinib. To date, more than 3,000 trial patients have discontinued TKI treatment, which proves it's feasible and it's safe. But successful discontinuation depends on how long you've been on TKI treatment and how deep your molecular response is. For any patient considering discontinuation, it should be discussed at MDT first, and they should be on an approved TKI therapy for at least 3 years. That patient shouldn't have a prior history of blast crisis or any previous resistance to a TKI or previous detection of BCI-ABL kinase domain mutation. The patient should also have achieved deep molecular response at MR4 or 5 at the subsequent milestones. You should also consider reducing the dose of the TKI by 50% for at least a year prior to discontinuing, with monthly monitoring. After you discontinue, monitoring should be really strict, so it should be monthly for 6 months, then 6 weekly from 7 to 12 months, then 2 monthly from 13 to 36 months, then 3 monthly after 3 years. If you've lost your molecular remission, then the TKI treatment should be reinitiated within a month. And if major molecular response is not achieved by 6 months, then kinase domain mutation analysis should be performed at that point. In terms of pregnancy, pharmacology databases suggest that the risk of adverse consequences in pregnancy for partners of men taking imatinib or dasatinib are similar to the normal population. In chronic phase, often the pregnancy can continue to term without intervention, although you might want to consider low-dose aspirin or low molecular weight heparin if there is thrombocytosis. There has been reports of imatinib and dasatinib causing congenital abnormalities in children, and therefore it's avoided completely throughout pregnancy. If treatment is required when the patient is pregnant, then options include leukapheresis, which poses the least risk to the fetus, or interferon. Interferon is generally considered safe in later stages of pregnancy, but TKIs are also secreted in breast milk, so therefore should be avoided when breastfeeding. Women with CML who want to conceive, you could get them into rapid remission with a second generation TKI, but once they've achieved molecular response, ideally they should have maintained this for at least a year at the MR4 milestone and not had any evidence of previous TKI resistance. I hope this video was useful. The sources I used was predominantly the BSH guidelines. The pictures were taken from learnheme.org and the guidelines were cross-checked with up-to-date. If you have any comments below or any suggestions for corrections, please contact me on the comments.